Good afternoon. My name is Dr. Hermien Creger, and I am faculty with Walden University School of Nursing and wanted to go over a video presentation of urinary symptoms and kidney disease in children. If we look at prevalence, we will see that about 5% of your office visits will involve urinary symptoms, but not all of them are actually UTIs. Black and Hispanic children are affected more with urinary symptoms or kidney disease than white children, and males are affected more than females. Risk factors include perinatal complications, neurological complications at birth or genetic conditions, males less than 1 year old or white females more than 4 year old are at a higher risk, uncircumcised males, and children with a family history of kidney disease. Before we go on, I wanted to familiarize you with the anatomy of the urinary system and the kidney. The urinary system includes the kidneys, usually two kidneys, the urethra that carries urine from the bladder, from the kidney to the bladder, and then you have the urethra that allows the flow of urine to the urinary opening. As far as the kidney itself, we know there's 1 million nephrons, usually housed in the renal capsule and cortex. And then we have the renal artery, the renal veil, the renal pelvis, and then the urethra there. So the function of the kidney is to help the body get rid of liquid waste, and we call that urea. It also manages electrolytes like sodium, potassium, and magnesium, control blood pressure, produce erythropoietin that control red blood cell production, and manages acid-base balances and conserve fluids. Let's start by looking at newborn kidney failure. So you will know that the kidney usually develops in utero as early as week 2 to 4. Concerns for the renal system are usually detected in utero and confirmed with antenatal ultrasound during the pregnancy. On the right here, we've got prerenal, intrarenal, and obstructive renal disease. So prerenal is congenital dysplasia, which is usually a failed nephron development, and that can be inherited or tetragenic. Then we have genetic kidney disease, where we have more commonly Alport's or autosomal polycystic kidney disease. Intrarenal, we have nonsteroidals or aminoglycosides used to close patent ductus, renal artery or renal vein thrombosis, or ischemic injury secondary to perinatal anoxia or placenta abruptia that prevents oxygen. Obstructive is upper and lower urinary tract disorders, hydronephrosis, or pelvic ureteric junction or vesicular ureteric junction obstructions. So this slide, we look at some congenital childhood kidney disease. 60% of the cases are usually of chronic kidney disease in children are usually due to congenital anomalies. So most common is polycystic kidney disease, usually affects bilateral kidneys. Then we have on the right here reflux disease, where we can have mild reflux, where urine is well, let's start by saying reflux is due to developmental anomalies of the vesicular ureteric junction. So this can be familiar, can be due to bladder pathology, or after a UTI, which can be temporary. It usually can be mild, where urine refluxes back up into the kidney as indicated on the left, and you will have mild urinary reflux with obstruction. Then on the right is a picture where we have a grossly dilated urethra, renal pelvis, and necrosis which are predisposing the intrarenal reflux and renal scarring, and this is usually common with a UTI. On the right, we have hydronephrosis. Usually, it can be unilateral, which means it's on the either side. In this picture, it can be one side or both sides. Then on the left, you've got the pelvic urethral junction obstruction, which is right below where the urethra flows out of the kidney pelvis. And if there is an obstruction there, it prevents the urine from flowing out, and it will enlarge the pelvis. On the right, the obstruction itself is at the bladder wall, which is the vesicular ureteric junction obstruction. And here the urethra, including the renal pelvis, will be enlarged and with urine. Bilateral hydronephrosis, usually bladder neck obstructions or post-urethral valves, and again, it can cause, the obstruction can be in the bladder itself or at the level as it enters the bladder, and this causes the hydrourethrus, which is the moderately dilated urethras, as everything is backing up before it actually enters into the pelvis. Then there is the horseshoe kidney, failure of development of the normal kidney, resulting in one solid kidney. And then there is Potter syndrome, very unfortunate genetic condition where there's bilateral renal agenesis or bilateral multicystic dysplastic kidneys. And it is a renal disorder, so they are unable to excrete urine. Usually it's picked up in vitro when you have too much fluid, and that causes fetal compression, which restricts development, and children born with this will have the Potter facies, which is low set ears, beaked kind of nose, prominent epicantic folds, usually downward, pulmonary hyperplasia causing respiratory failure, and severe limb deformities. So most of the problems that we have in CKD are usually in the kidney itself, so it can be glomerular or non-glomerular disorders. So non-glomerular disorders, so those are usually structural abnormalities, present with symptoms of polyuria. So they pee a lot and they're really not concentrating their urine, elevated serum creatinine, and poor growth. Whereas glomerular disorders typically presents with gross hematuria, because it's the nephrons itself that's bleeding, nephrotic protein more than 1,000, elevated creatinine, and hypertension. These children usually present with swelling in their legs, fevers, arthralgias, arthritis, rush, or pulmonary symptoms. Next, we look at children at the ages 2 to 19 years old and see who is at risk. Those are usually children that you know that have difficulty at birth, with birth blockages either in the upper or the lower tract, or reflux disease. It can also be children that had sepsis or pneumonia and had complications following that, including shock or acute blood loss or traumatic events or surgeries. High-risk medications that are renal toxins, we think here about our aminoglycosides, E. coli diarrhea resulting in dehydration or hemolytic uremic syndrome, HUS, can cause severe kidney problems for children 2 to 19 years old, mostly because of the glomerular disease, but also of dehydration. Glomerulonephritis due to hypertension, lupus, obesity, and diabetes. And then neurodevelopmental and neurocognitive delay. Children that have any of those symptoms needs to be screened for kidney disease. So let's look at who you will see in the office. So children with genetic conditions or congenital kidney disease will establish care post-birth. They will see a nephrologist once or twice a year, depending on the disease or the congenital deformity, but in general, they are in your office under your care. Caution though that early stages of CKD is asymptomatic, so you kind of have to screen them for this, and we will look at symptoms here below. And then late development onset of CKD is only apparent when there's proteinuria due to diabetes and hypertension, and we usually pick that up when we do our school, back to school physicals. So symptoms that will prompt evaluation for risk factors are poor growth reflecting and milestones. Boy, lots of mistake there. Weakness and fatigue, tea-colored urine, feeding difficulty, elevated blood pressure, and edema. So this slide relates your symptoms to what it potentially can be. So poor growth is usually detected with a growth chart or a delay in achieving milestones, so that should be a red flag for you. Weakness and fatigue may be related to uremia or anemia of chronic kidney disease. Tea-colored urine is usually associated with hematuria, red blood cell cast, and almost always indicate glomerulonephritis. Feeding difficulties or anorexia, mostly related to uremia. They have persistent nausea, vomiting, and bloating. Elevated blood pressure may be a sign of CKD. Frank hematuria may indicate may be incidental after sports injury or trauma, but can also indicate glomerular disease. Proteinuria is strongly associated as a biomarker for CKD2 related to glomerulonephritis and tubular dysfunction. Edema, usually associated with volume overload, secondary to nephrotic range proteinuria, and that would be your protein more than 800 to 1,000 on a urine analysis. And then an elevated creatinine, use that to calculate your GFR, and you can predict the severity of kidney disease, stage 1, 2, 3, 4, and 5, and then end stage. So how do we work up children for kidney disease? So start with a good review of symptoms. I always say a good interview will give you your diagnosis, and you don't even have to order anything, or you can just use your orders to confirm it. But review the family history for risk of chronic kidney disease, hypertension, diabetes, lupus, congenital disorders, or very strong family history of CKD. Focus the review system on CKD, like symptoms of polyuria, polydipsia, enuresis, hematuria, or failure to achieve dry milestones by the age of 5 years old. Review your growth chart for poor linear growth, usually in that lower 15 to 45% is always concerning. Screen for elevated blood pressure, diabetes, and anemia. Ask about recurrent urinary tract infections. Screen for edema, and screen for electrolyte changes. And then I just, in the box here on the right, I wanted to remind you to know your terminology when you ask your parents. Incontinence is involuntary leaking. Urgency is a sudden, strong need. Dysuria is burning or pain with urinating. Hesitancy is a delay starting the urine. Straining is forcing the urine out. And nocturia is urinating at night. Right, let's move on to the physical exam. So very important measurements of growth parameters. You want to know their height, their weight, and their head circumference in, if they are less than 3 years old. And you will plot that on your growth chart that will give you a relation to peers their age. You're going to do your abdominal exam to palpate for any masses, tenderness, or stool. You're going to do a genital urinary and genital exam. Look at the Tanner stage, appropriate for their age, genital symmetry, lesions, or discharge noted. Then you're going to look at the spine. We particularly look for dimples or tufts of hair in the lower lumbar area, and spina bifida, because this may be signs that there were a neurodevelopmental concern. And then we will look at skeletal deformities. This bone and mineral disorders can affect their growth, and that may suggest chronic kidney disease. Lab work. So for kidney disease, we use a BMP or a CMP, where we see the blood urine nitrogen, the serum creatinine, and then we use that, or nowadays our lab calculates it for us, the glomerular filtration rate. Schwarz occasion for CKD and a BON creatinine ratio. And then based on that, you can evaluate your kidney disease. You're going to look at a urine analysis for cells, protein, blood, pH, and osmolality. And I have a slide coming up where we're going to look at urine in depth. And then order labs as indicated by their symptoms, or to rule out your differential diagnosis. So pallor and fatigue can be because of anemia, so you want to check a H&H. But it can also be thyroid disorder, so you check your TSH, free T4, and free T4. If they present with edema, you want to look at urine and plasma electrolytes, urine and plasma osmolality, protein creatinine ratio, and I don't have it on there, but the albumin is also very important. Skeletal deformities, look at your calcium, your intact parathyroid hormone, your phosphorus level, your 25-dihydroxyvitamin D to make sure those are normal. Stunted growth or delayed puberty, you are not just going to look at renal disease, but you are going to look at their growth hormones, testosterone for boys, and follicular stimulating growth for girls, FSGA. Right, so what kind of imaging should we order? So you can do a simple bladder scan for suspected urine retention. If you feel your pelvic exam may have some large volume in the bladder, you can bladder scan them. Quickly shows you how much you have in there. A simple renal ultrasound and duplex will tell you about anatomical concerns. That is your size, 1 kidney or 2 kidneys, renal artery, renal vein. And this is usually recommended when you have 2 UTIs in 6 months, if you are concerned about size of the kidney, symmetry, or anatomical problems. Usually order that if you have a child with hematuria, urine retention, or if you are suspecting hydronephrosis because of acute kidney injury. Then you've got avoiding cystourethrogram when you are suspecting urine retention or urine reflux. CT scan to visualize kidney and urinary tract or kidney vasculature. This is also where you would see your pyelonephritis, but be aware, contrast, is nephrotoxic. So if you have a child with a creatinine of 2, you're probably not going to order this because it may make things worse for them. Then you have your MRI. If there's suspected neurological concerns, tumors, lesions, or anatomical problems that you are concerned about. And then finally, your renal biopsy, where you get a tissue sample if you suspect glomerulonephritis or sclerosis of the kidney. This is usually ordered by a nephrologist, so you will make a referral to the nephrologist and he will tell you, hey, I think it's a good idea to do a biopsy. Right, let's move on now and look at bladder function milestones. These are very important in our little ones, and the little box on the right kind of shows you bedwetting numbers by age. By the age of 4 years old, children should be dry during the day most of the time. Accidental nocturnal bedwetting can happen up to 5 years old, and after 5 years old, it can happen both in day and night, except with the exception of enuresis. So enuresis is 4 different categories. Diurnal enuresis is usually more common in girls than boys. They have accidents because they are holding it too long, they are playing too long, they're distracted, they're too shy to say they have to go to the bathroom, or they have an overactive or an underactive bladder. Nocturnal enuresis is usually boys more than girls. No specific cause for it, but there is a very strong familial link. And they may outgrow it, but if you do have a boy with nocturnal enuresis, then it's important that you ask the father if he had a problem with it, because the child will have it's the same. Then we have primary enuresis, means they are never dry. We usually see this in our neurodevelopmental children, may present with uncontrolled bathroom or bladder problems. And then secondary enuresis is usually when it reoccurs after they've been actually dry for more than 6 months. Important to note though, usually there is no physical or emotional problem with these children. Now it may happen that at the same time it starts, mom and dad are separating or they move to a new school. It can to some level play into the factors, but usually emotional and physically there is no problem. And then it's also important to rule out other health conditions like constipation, spina bifida, vesicular urethral reflex, obstructive sleep apnea, and ADHD. Those oftentimes may run horizontal with or in linear with the bedwetting. Right, so I told you earlier we will look at a urine analysis here earlier. So here are our review of a urine analysis as you would see it. So physically you will look at the color and the clarity. Normal is usually straw colored, pink is grapefruit colored, then there is cranberry colored when it is literally color of cranberry, and then when it's bloody and red, just hematuria, or they call it Merlot. But that will vary with hydration. So when they're hydrated, it would be nice and light yellow, straw colored, whereas when they are dehydrated, it may be more concentrated. Just think about your own urine too. So then as far as chemical, pH is usually 4 to 5.8 and is usually acid-base status, can be related to some infections if you look at your pH, especially Pseudomonas. But it can also indicate that there may be a loop problem, nephritis in the kidney itself when they are unable to concentrate urine. Specific gravity we talked about is usually related to hydration or loop problems. Leukocyte esterase is usually negative. With the addition of white blood cells, it can usually indicate infection. Nitrates, usually not there, but common when there is a nitrate reducing bacteria. Protein, shouldn't have any protein in your kidneys, with the exception of young athletes that eat like their body mass plus 30%. I don't know what the calculation even is, but they eat mega amounts of protein and protein supplements. They are going to pee protein out, so you have to ask about that. Or if they had strenuous activity, they ran a marathon, they are going to pee both blood and protein. And then it can also be a sign of renal disease, because those little nephrons are breaking. Instead of catching the proteins and putting it back into the system for circulation back to the body, it comes through the filter and you see the protein in the urine. Glucose shouldn't be in your urine except if there's diabetes or hyperglycemia, and of course, on your GLP-2 diabetic drugs. If there is a teenager that's using that, you will see like 1,000 of glucose in their urine. So ask about that too. It can be medication. Ketones usually shouldn't be in there, with the exception of diabetes, usually type 1 uncontrolled diabetic ketoacidosis or starvation. Bilirubin shouldn't be in there unless there is some form of liver disorder. Bilirubin, again negative, only there if there is urinary liver disease or hemolysis. Blood shouldn't be in your urine, but there can be hematuria due to trauma, rhabdomyolysis. Like I said, they ran a marathon. They're gonna have blood in there. So always ask about the circumstances. Red blood cells or white blood cells. Few, but mostly none in there. But you will see it when you have infections, stones, or inflammation or infection in the kidney, nephritis. Casts are rare, but it usually is in there when you have dehydration. They will have casts in there, but you also may have uremic cast, or you may have casts from crystals like that are forming uric acid crystals may also shows. And there it is, crystals, stone risk or metabolic disease. And then bacteria and yeast shouldn't be in there, but if they are, it's usually an infection. Right, so speaking of infections, let's look at the top bacterial pathogens for children. 80 to 90% of the time, it's going to be E. coli, especially if it's a first-timer or a community-acquired UTI. Klebsiella, 5 to 10%, usually recurrent or hospital-associated UTIs. Proteus mirabilis, 5 to 10%, very common in uncircumcised boys or children with urinary tract abnormalities, vesicular reflux kind of thing. And Enterococcus, gram-positive, usually catheter-associated or urinary tract abnormalities. Again, here we have our children with neurocognitive developmental disorders that may have neurogenic bladder, and they have to have a catheter in or a suprapubic tube. We will see this. Then you have Pseudomonas, Pseudomonas aeruginosus, or Pseudomonas A, less than 5%. Again, structural anomalies or prior antibiotic exposures. And then Enterobacter, less than 5%, usually seen hospitalized patients or recurrent cases where they've been treated with antibiotics repeatedly. They may develop Enterobacter, and that's why we are so insisting on our students kind of grooming themselves to be stewards of good antibiotic use. Right, treatment options. So, of course, treatment options are going to depend on your bacteria, and this is where that wait till your culture is pending. Now, if you have a child that presents with a fever, tachycardia, diaphoretic, you're not going to wait for a culture. We know 80 to 90% are usually E. coli. You're going to treat them. Treatment options for children more than 2 months old, afebrile with lower UTI or cystitis. We're going to do Keflex, nitrofurantoin, or Bactrim, and there are your doses, milligrams per kilograms. On the right, important information: avoid nitrofurantoin if febrile UTI because of poor tissue absorption, and Bactrim may not cover resistant E. coli, even though it's our most common one. But if they've had more than one E. coli UTI, Bactrim is probably not your first choice. Febrile UTIs, pyelonephritis, while appearing means you've seen it on a CT scan. It's not just flank pain, fever, and tachycardia. These children will need to be hospitalized, and they get ceftonir, cefaxime, or amoxicillin clavuculate augmentin. This has very good kidney penetration, but make sure you check your E. coli resistant rates, not just for your hospital, but also if it is a child that's had multiple infections. So considerations for resistance, if you treat it, like I said up here, then, and now you have a problem with it, uncomplicated cystitis 3 to 5 days, febrile UTI pyelonephritis 7 to 14 days. But if you treat it and the symptoms doesn't resolve, look for recurrent UTIs, recent antibiotic use, known anatomical abnormalities or renal stones, a history of resistant organisms, or if they were recently hospitalized or institutionalized. Right, so we wrap it up by discussing challenges of kidney disease. Children with kidney disease are at a disadvantage because it may delay their language skills development. They may have trouble concentrating and problem solving. It's that uremia. They may have behavioral problems. They may have relationship problems, and they may have self-image problems. So management of kidney disease takes a village. Kidney disease is progressive. So we say focus on developing an organized surveillance and maintenance plan that focus on early detection and management of complications. So look at what the mom tells you and see if there is a concern that you should chase down. You have to manage the metabolic complications. You need to refer to a pediatric nephrologist. They will give you not only the stage of kidney disease, but as they grow, they may need referral to a urologist, or they may already see a urologist. And then initiate families, social, school, social services, and community support so that they can have the optimal treatments. Righto. I thank you for the time that you spent reviewing this PowerPoint with me. I feel that the more you read, the more things you will know, and the more that you learn, the more places you will go. That's Dr. Seuss, as you all know. I hope that you find this helpful, and I appreciate your time. Have a good day.